When I was thinking about how to talk about it, I thought really I'm going to give you a journey, a little bit different than normal, and talk about where we were, where we're going, the rationale, how we got there. And really I have to thank Tony Calabro is here as my associate. We've worked together for more years than I can think, and Tony does the lab work, and Julia Tai from Biostatistics has helped us with interpreting what we came up with. And let's go and see what happens. And it really first goes back to Dr. Ehrlich, and for those of you that are interested in history of medicine, as we get older, I think we get more interested. In 1908, he won the Nobel Prize for his work in immunology. In 1915, he probably would have won the Nobel Prize again for his work in anti-infectives, but unfortunately he died at the age of 56 of diabetes. But what we know about him in one of his statements was, when you take a journey in a balloon, you cannot always tell what the scenery will be like when you land, but you can keep your eyes open and see what's there. And I hope to try to do that today. He was responsible for targeted therapy, therapeutic index, a lot of immunology, animal models of cancer, stains for bacteriology, and rationally derived drugs. And it boggles the mind to think that anyone could do that much. Now, why are we interested in drugs and drug synergy? Well, we know that the currently available drugs we have, for curable solid tumors, you need combination drugs. And I particularly got interested in one area, and that was breast cancer, because we ended up staying in the New York area. I was outvoted by my wife. And the breast activists were very vocal. And I said, gee, this is an endemic disease, and perhaps I should be interested in it. And actually, what you see here is that Seattle is really the worst area. So these are things that one doesn't really think of. Everybody thinks New York, Long Island's the worst, but Seattle and Connecticut. So we're in a less endemic area. And this you've seen before. This is the classic Weinberg article. And what I'm going to just talk about today really is apoptosis. And I'm not going to talk about any of the other areas. Now, what we have is an explosion of molecular biology, and we really have is a tremendous number of new drugs in development to boggle the mind. And indeed, there are 400 drugs in development, and I just show you this as a panoply, and I'll discuss it a little bit later on. The problem we have is we don't have very good surrogate markers of what is a really good drug and what isn't. And if we look at drug development, it takes over 15 years from the genesis in the laboratory to actually get it approved by the FDA. And only 1 out of 40 drugs that is in phase 1 actually makes it to market. Very frustrating area for us to work in. And then you have the drug on the market, and it takes you time to figure out where to use it and how long to use it. And if you look, for example, at 5-fluorouracil, it took 50 years to figure out how to give it, especially when we have lots of drugs. Now, our area, for example, in breast cancer, though, is getting more complicated. And it's getting complicated because both from a genomic standpoint, and you know this well, and a proteomic, there is tremendous heterogeneity in these diseases. And they act biologically different, both in the patient and as far as their response to therapy. Basal and HER2, as you know, a very aggressive disease. Usually women, if they survive 5 years, do not get a recurrence. On the other hand, luminal A is a very indolent disease, and even 20 years out, women relapse with that disease. On the other hand, the more fulminant diseases respond better to the drugs we currently have. And unfortunately, in the clinic, we've sort of lumped all these patients together, and now we have to go back and figure out which drugs are really good for which.